Welcome back to SurgiSmart Cut to the Core, where we break down these essential surgical topics, to help you really understand surgical conditions. I'm your host, Major Munish Chauhan, and I'm a general surgery registrar in the British Army and at Oxford Deanery. I'm also a senior research fellow at the Center for Army Leadership. Feel free to connect with me on LinkedIn if you've got any questions or, just interested in these topics. Today, we're diving deep into a surgical emergency that can really turn a surgeon's day upside down. Esophageal perforation and rupture. Think about it. The esophagus, this vital pathway for everything we eat and drink, suddenly springs a leak. That's not just a plumbing issue, it's a recipe for disaster. We'll unpack why this happens, what signs you absolutely can't miss, and how to manage it effectively, because with this condition, swift action is the difference between life and death. First things first, let's define what an esophageal perforation actually is. Imagine the esophagus is a delicate tube, right? Now picture a full-thickness tear in that tube. That's a perforation. It creates an opening, a breach in the wall, and suddenly all those digestive juices, food particles, whatever was in the esophagus, can spill out into the surrounding areas, particularly the mediastinum. You can imagine the chaos this causes. It's like a burst pipe in a delicate ecosystem. This leakage triggers a cascade of complications. Mediastinitis, inflammation of the chest cavity is a big one, and then there's sepsis, a systemic inflammatory response that can quickly become life-threatening. Now, thankfully, esophageal perforation isn't something you see every day. It's relatively rare, affecting about 3 in every million people annually. But here's the catch. When it does happen, it's a serious situation. And the reason it demands our utmost attention is the stark reality of the survival rates. If we intervene late, the chances of survival plummet to a dismal 10%. But if we catch it early and act decisively, the survival rate jumps to a much more hopeful 70%. That's a 60% difference. It really hammers home the point that time is of the essence with this condition.
So recognizing the signs early and initiating treatment promptly can literally mean the difference between life and death for our patients. Now let's delve into why esophageal perforation happens in the first place. Understanding the causes is crucial for prompt diagnosis and management. Broadly, there are 3 main ways this can happen. The first is what we call Boerhaave syndrome, a spontaneous rupture of the esophagus due to a sudden, intense spike in pressure. Picture this. You've had a large meal, maybe one too many drinks, and you experience forceful vomiting or retching. That intense pressure can overwhelm the esophageal wall, causing it to rupture. And there's a classic profile we see with this. Middle-aged men, perhaps after a particularly indulgent meal or a bit too much alcohol, it's almost like a cautionary tale about the consequences of overindulgence. The second category is iatrogenic perforations. This means the perforation is a consequence of a medical procedure. Might seem counterintuitive, but even procedures intended to help, like endoscopy, dilations, or foreign body removal, can sometimes lead to this complication.
And believe it or not, this is actually the most common culprit, accounting for a whopping 60% of cases. Several factors can contribute to this. An inexperienced operator, complex anatomy in the patient, or pre-existing conditions like strictures or tumors can make these procedures more challenging and increase the risk of perforation. Finally, we have traumatic perforations, which, as the name suggests, are caused by injury. This could be external trauma, like a blunt force to the chest or a penetrating injury to the neck. You can imagine the kind of impact that could lead to a tear in the esophagus. But trauma can also be internal. Swallowing sharp objects like a chicken bone or a toothpick or ingesting caustic substances can also cause perforations. So we've got a good grasp of the potential causes. And the million-dollar question is, how do we know what's happening? How do we identify this condition in our patients? The good news is that esophageal perforation tends to present quite dramatically. The patient is usually in a lot of distress. However, the specific symptoms can vary depending on the location and size of the tear. Let's break down the red flags you need to watch out for.
The hallmark symptom is severe chest pain, typically described as sharp, tearing, or stabbing. It's usually located right behind the breastbone, and gets worse with swallowing or even deep breathing. Think about it. Every swallow or breath becomes excruciating. That's a telltale sign that something is seriously wrong. Another sign you might encounter is subcutaneous emphysema. This is when air leaks from the perforation and gets trapped under the skin. You can actually feel a crackling sensation when you press on the area. It's like bubble wrap under the skin. Patients might also experience vomiting difficulty swallowing or even vomiting blood. As the condition progresses and those dreaded complications like mediastinitis set in, you'll start to see systemic signs of infection, fever, a rapid heartbeat, low blood pressure, and even altered mental state. And here's a fascinating clinical pearl for you, Hammond's sign. This is a crunching sound that occurs in sync with the heartbeat. It's a very specific sign that indicates air has entered the mediastinum. It's not something you'll hear every day, but when you do, it's a significant clue. So you're examining a patient and you suspect an esophageal perforation. What's next?
Confirmation of the diagnosis is critical, and we need to do it quickly. Every minute counts. The gold standard for diagnosing esophageal perforation is a contrast-enhanced CT scan of the chest. This imaging technique allows us to visualize the esophagus and see if there's any leakage of the contrast material, which would indicate a tear. Think of it like a dye test for your esophagus. The CT scan can also detect air in the mediastinum or any fluid buildup, further supporting the diagnosis. Endoscopy, where we directly visualize the esophagus with a camera, can also be helpful. It allows us to pinpoint the exact location and size of the perforation. But there's a caveat. Endoscopy carries a risk of potentially making the tear worse, especially if the patient is already unstable, so it's not always the first choice. A chest X-ray can also be done, though it's not as sensitive as a CT scan. It might show indirect signs of a perforation, like air or fluid where it shouldn't be, but it's not as definitive. The key takeaway here is that early diagnosis is paramount. The sooner we identify the perforation, the sooner we can intervene and improve the chances of a positive outcome. Now that we've covered the causes, presentation, and diagnosis, let's talk about management. What do we do once we've confirmed an esophageal perforation? Well, there's no one-size-fits-all answer. The approach is multifaceted and depends on several factors. The size and location of the tear, how long ago it happened, and how sick the patient is. In some cases, we might opt for conservative management. This is typically reserved for smaller contained perforations in stable patients without sepsis. It involves strategies like keeping the patient NPO, strictly nothing by mouth, and start him on intravenous fluids, broad-spectrum antibiotics, and using medications to reduce stomach acid production. It's all about giving the esophagus a chance to heal on its own. But when the perforation is large, uncontained, or the patient is showing signs of sepsis, surgery becomes necessary. There are a few different surgical options available. Primary repair involves directly stitching up the tear in the esophagus, often reinforced with a tissue flap for extra strength. If the damage is extensive or there's concern about cancer, we might need to remove a portion of the esophagus entirely. This is called an esophageal resection. Regardless of the specific surgical technique, drainage is crucial. We use chest tubes to manage any buildup of pus or abscesses that may have formed due to the perforation. And recently, endoscopic interventions, particularly stenting, have been gaining popularity as a less invasive way to manage certain perforations. Stenting involves placing a small tube-like device into the esophagus to seal the tear and promote healing. It's like scaffolding for the esophagus. Now, even after successful surgery, post-operative care is critical. Patients need antibiotics, nutritional support, and close monitoring for complications like narrowing of the esophagus or recurrent infection. So we've discussed various management strategies, but the question that weighs heavily on our minds is, what are the odds of recovery? Unfortunately, even with the best care, esophageal perforation remains a serious condition. Mediastinitis and sepsis are formidable foes, and they can be tough to beat. But there's a powerful message of hope here. You know how we keep emphasizing that time is critical? Well, the numbers back it up. Surgical repair within 24 hours of the perforation can lead to success rates as high as 90%.
On the other hand, when treatment is delayed, that success rate plummets sometimes to as low as 50%. This really drives home the point that early recognition and intervention are absolutely paramount in improving outcomes for our patients. So we've covered a lot of ground in this deep dive into esophageal perforation. It's a surgical emergency with potential for serious complications, even death. But here's the good news. We know what to look for, we know how to diagnose it, and we have a range of management options at our disposal. And most importantly, we know that time is our most valuable ally. Early recognition of those telltale signs like chest pain and subcutaneous emphysema, combined with prompt imaging and decisive intervention, can make all the difference. We've explored management strategies from conservative measures like NPO and antibiotics to surgical interventions like primary repair, resection, and stenting. And we've highlighted the critical importance of post-operative care, ensuring patients receive ongoing antibiotics, nutritional support, and close monitoring for any signs of trouble. Before we wrap up this first part of our deep dive, I want to leave you with a few points to ponder.
First, esophageal perforation is a master of disguise. Its symptoms can mimic other conditions, making diagnosis tricky. So if a patient comes in with severe chest pain, especially after vomiting, or a procedure involving the esophagus, keep this condition on your radar. Second, remember that teamwork is key. Managing this condition effectively requires a multidisciplinary approach with collaboration between surgeons, gastroenterologists, radiologists, and intensivists, to name a few. And finally, never underestimate the power of patient education. Empowering patients with knowledge about the potential causes and symptoms of esophageal perforation can encourage them to seek help sooner, which can dramatically improve their outcomes. We'll be back in the next part of our deep dive to discuss real-world case studies and specific scenarios you might encounter in your practice. Stay tuned, and until then, keep learning, keep bleeding, and stay resilient. Welcome back to SurgiSmart Cut to the Core. We're in the thick of our deep dive into esophageal perforation, a condition that demands both knowledge and swift action. In this part, we're going beyond the textbook. Let's step into the shoes of a surgeon, facing real-world scenarios, those moments when theory meets the unpredictable reality of clinical practice. Picture this. It's Friday night in the ER, and a middle-aged man, let's call him Mr. Jones, comes in with intense chest pain. He's clutching his chest, barely able to speak. He tells you between gasps that he had a massive meal earlier, followed by an episode of, forceful vomiting, and then bam, this excruciating pain hit him like a ton of bricks. Examining him, you notice a crackling sensation under his skin when you press on his chest, that telltale subcutaneous emphysema. And when you listen to his heart, you hear it. Hammond's sign, that crunching sound in sync with each beat. Alarm bells are ringing in your head. You rush him for a contrast-enhanced CT scan, and there it is. A small perforation in the lower part of his esophagus. Thankfully, he's relatively stable, his vitals are within a reasonable range, and there's no sign of sepsis yet. Now, what would you do? In this scenario, conservative management is a reasonable approach. We'd keep Mr. Jones' MPO strictly nothing by mouth and start him on intravenous fluids, broad-spectrum antibiotics, and medications to suppress his stomach acid production. We're giving his body a chance to heal itself, and we're watching him like a hawk for any signs of deterioration. A few days later, Mr. Jones is doing much better. The pain has subsided, that crackling under his skin is gone, and a repeat CT scan shows the perforation has healed beautifully. This is a prime example of how prompt recognition and early conservative management can lead to excellent outcomes in selected cases. But now imagine a different scenario. A young woman, Miss Smith, is brought in after a horrific car accident. She has blunt trauma to the chest, struggling to breathe, and can barely swallow. You examine her and find bruising on her chest wall, and again you feel that subcutaneous emphysema. A chest x-ray shows air in her mediastinum, and a contrast-enhanced CT confirms your worst fear. A large jagged perforation in the middle of her esophagus. Her blood pressure is plummeting. Her heart is racing. She's showing all the signs of shock. This is a completely different ballgame. In this situation, there's no time to waste. We're talking immediate surgical intervention. Miss Smith is rushed to the operating room, where a skilled surgical team will repair the perforation, reinforce it with a tissue flap, and place chest tubes to drain any fluid or air buildup. Her post-op care will be intensive, likely in the ICU, with vigilant monitoring and aggressive support. This case highlights the crucial role of surgery in managing complex and severe perforations, especially if they're caused by trauma. Sometimes it's the only way to save a life. Now let's explore a third scenario, one that showcases the growing role of minimally invasive techniques. Mr. Brown, a man in his late 50s, comes to your clinic with a history of esophageal cancer. He recently underwent a dilation procedure to widen a narrowing in his esophagus caused by the tumor. But a few days later, he develops chest pain and a fever. A CT scan reveals a small perforation right at the site of the dilation. He's stable, no signs of sepsis, but the perforation needs to be addressed. This is where endoscopic stenting shines. Instead of open surgery, we can go in with an endoscope, place stent across the perforation, sealing it off and allowing it to heal. It's like a tiny internal scaffolding that provides support and promotes healing. These three scenarios highlight the importance of individualized treatment. Each patient, each perforation is unique, and the optimal management strategy must be tailored to the specific circumstances. So we've seen the spectrum from conservative management to life-saving surgery and innovative, minimally invasive approaches. But the decision-making process doesn't stop there. Let's dive deeper into conservative management. Remember, it's not just a wait-and-see approach. It's a carefully considered strategy with its own set of indications and contraindications. The ideal candidate for conservative management is someone like our first case, Mr. Jones, a stable patient with a small contained perforation and no signs of sepsis. But there are other factors to consider. Can the patient tolerate being MPO, or do they have other medical conditions that require them to eat? Are they reliable enough to adhere to the strict restrictions of conservative management? Are we equipped to monitor them closely for any signs of deterioration? Because here's the thing. While conservative management avoids the risks of surgery, it's not without its own potential downsides. What if we miss a subtle sign of worsening infection? What if the perforation, despite being small, doesn't heal properly? Time is always of the essence, and a delay in recognizing the need for surgery can have devastating consequences. So conservative management is a powerful tool in our arsenal, but it demands careful patient selection, meticulous monitoring, and a low threshold for escalating to surgery if needed. Now let's shift gears and talk about nutrition. It might seem like a basic concept, but in the context of esophageal perforation, it's absolutely critical. Think about it. The esophagus is the gateway to the stomach. When it's compromised, the normal route for food intake is disrupted. Our patients are NPO unable to eat or drink normally. This can have a huge impact on their ability to heal and recover. In the initial stages, we can manage with intravenous fluids, providing hydration and electrolytes. But for long-term healing, we need something more substantial. This is where enteral nutrition or tube feeding comes into play. Imagine bypassing the damaged esophagus altogether. We can deliver specially formulated liquid nutrition directly into the stomach or small intestine through a tube. This allows for a more physiological delivery of nutrients, supports gut function, and reduces the risk of complications. But even tube feeding isn't always feasible or sufficient. In some cases, we might need to resort to parenteral nutrition, where nutrients are delivered directly into the bloodstream. The takeaway here is that early and aggressive nutritional support is essential in managing esophageal perforation. It's not just about calories, it's about providing the building blocks for healing, boosting the immune system, and giving our patients the best chance of recovery. Now let's address another cornerstone of management: antibiotics. Remember that breach in the esophageal wall we talked about? Well, it's not just a leak of food and digestive juices. It's a potential gateway for bacteria to invade the surrounding tissues, leading to mediastinitis sepsis and other life-threatening infections. Antibiotics are our weapon of choice in this battle. We usually start with broad-spectrum antibiotics covering a wide range of potential culprits while we wait for culture results. Once we know the specific bacteria involved, we can fine-tune the antibiotic regimen for maximum effectiveness. And it's not just about treating existing infections. Antibiotics also play a key role in preventing infections, especially after surgical repair. But remember, antibiotics are a double-edged sword. Overuse can lead to antibiotic resistance, a growing threat to public health. So we use them judiciously, ensuring appropriate selection, dosage, and duration. Now let's talk about something that's often overlooked but equally important: pain management. Imagine the pain of a torn esophagus. Every breath, every swallow could be excruciating. Untreated pain is not just a matter of discomfort. It can hinder healing, lead to anxiety and sleep disturbances, and even delay recovery.
So effective pain management is not just about comfort. It's an integral part of our management strategy. We have a range of options at our disposal, from simple analgesics like acetaminophen and NSAIDs to potent opioids for severe pain. We can also use nerve blocks and epidural analgesia to provide targeted pain relief. And don't forget the power of non-pharmacological approaches. Simple things like positioning heat or cold therapy and relaxation techniques can make a world of difference. The key is to individualize pain management considering the severity of pain, the patient's preferences, and the potential risks and benefits of each option. We've covered a lot of ground in this second part of our deep dive. We've walked through real-world scenarios, explored the nuances of conservative management, emphasized the importance of nutrition and antibiotics, and highlighted the often overlooked aspect of pain management. In the final part of our deep dive, we'll discuss the prognosis of esophageal perforation, the potential long-term complications, and the psychological impact this condition can have on our patients. Stay tuned. Welcome back to SurgiSmart Cut to the Core.
We're in the final stretch of our deep dive into esophageal perforation. And now that we've tackled, the management side of things, let's talk about what happens after that initial crisis. It's easy to focus on the immediate threat, but with this condition, the story doesn't end there. So firstly, let's address the elephant in the room. What are the chances of a full recovery? Well, the prognosis is a bit of a mixed bag, to be honest. Esophageal perforation, even with the best care, is a serious condition. The good news is with prompt diagnosis and treatment, survival rates can be as high as 90%. It's pretty remarkable, right? But here's the reality check. Delaying treatment even by a day can drastically reduce those odds. That's why everything we've talked about, from recognizing those subtle signs to acting fast, it's so critical. And even when treatment is successful, there's still the possibility of long-term complications. It's like a battle won, but with some lasting scars. One of the most common issues we see is stricture formation. Imagine the esophagus healing, but with some narrowing at the site of the tear. This can make swallowing difficult, especially for solid foods. Patients might complain of food getting stuck, regurgitation, even chest pain. It's like the esophagus has developed a bit of a bottleneck. If a stricture does develop, we have options. Endoscopic dilation, where we gently stretch the narrowed area, is often effective. But sometimes surgery is needed to remove the stricture completely. Another worry is recurrent leaks. Imagine going through all the trouble of repairing a perforation only for it to reopen. It's like a wound that just won't stay closed. This can be due to infection, poor healing, or even increased pressure in the esophagus. The symptoms are similar to the initial perforation: fever, chest pain, shortness of breath. It's a red alert situation. Managing a recurrent leak can be tricky. Sometimes another surgery is needed, but stenting can also be a viable option. Beyond those two biggies, some patients experience long-term swallowing difficulties even without a stricture or leak. This could be due to nerve damage, scar tissue, or weakness in the muscles involved in swallowing. For these folks, working with a speech therapist can be immensely helpful in retraining those swallowing mechanisms. And in some cases, a feeding tube might be necessary, at least temporarily, to ensure proper nutrition. So even with the best possible outcome, there can be bumps in the road to recovery. And this brings us to a crucial aspect that's often overlooked: the psychological impact of esophageal perforation. Think about it. You've just faced a life-threatening condition, undergone surgery or intensive treatment, and now you're dealing with the fear of complications and the uncertainty of what the future holds, right? It's a lot to process, and it's understandable that patients may experience, a whirlwind of emotions: fear, anxiety, even anger or depression. Some might be overwhelmed by the thought of eating, constantly worried about food getting stuck or triggering another perforation. And here's the thing: those emotional struggles can manifest physically too. Increased heart rate, rapid breathing, nausea, the whole works. So as surgeons, we can't just focus on stitching up the physical wound. We need to address the emotional scars as well. Active listening, validating their fears, and providing clear, empathetic communication are essential. Connecting patients with support groups or therapists can be a game changer. It's all about treating the whole patient, not just the perforation. Now, before we wrap up, let's shift gears one last time and talk about prevention. Because as we all know, sometimes the best surgery is the one we don't have to perform. While we can't completely eliminate the risk of esophageal perforation, we can certainly minimize it. And that starts with understanding the different causes, right? For iatrogenic perforations, those caused by medical procedures, it's all about meticulous technique, careful patient selection, and having experienced operators on board. For those caused by trauma, prevention is all about minimizing the risk of injury in the first place. Seat belts, protective gear during sports, that sort of thing. When it comes to spontaneous rupture, education is key. Moderation in alcohol consumption and recognizing the warning signs of forceful vomiting can go a long way. And finally, let's not forget about foreign objects. We've all heard stories of people swallowing things they shouldn't, and this is where common sense and careful eating habits come into play. So while esophageal perforation may be a relatively rare condition, the lessons it teaches us are profound. It highlights the importance of a multidisciplinary approach, the constant need for research and innovation in our field, and the crucial role of patient education and empowerment. It reminds us that every case is unique, that treatment decisions need to be individualized, and that addressing the psychological impact of this condition is just as important as managing the physical wound. And perhaps most importantly, it underscores the power of prevention, of taking steps to minimize risk and avoid this potentially devastating condition altogether. This deep dive into esophageal perforation has taken us on a journey from the anatomy of a tear to the complexities of treatment, the challenges of recovery, and the importance of a holistic approach. I hope you've gained valuable insights that you can apply to your own practice, whether you're a seasoned surgeon or just starting your medical journey. Remember, knowledge is power. And in surgery, that power translates into saving lives and improving the well-being of our patients. As always, thank you for joining me on SurgiSmart Cut to the Core. I'm Major Munish Chauhan, and I'll see you in the next deep dive. Until then, keep learning, keep leading, and stay resilient.